Hello and good evening. My name is Nick Bletsky and I'm proud to welcome you to the first industry webinar, educational webinar from ESRA. Pre-peritoneal wound infiltration catheter in laparoscopic colorectal surgery. This webinar is provided to you by Pajunk. We have more than 1,100 registrations and we are very happy to see that much interest in this educational offering. Please note that this is a free, non-CME webinar. Since we are going with a webinar setup, there's no microphone and no video available for the attendees. Only the presenters can be seen and heard. If you want to communicate with other attendees, please pick the right recipient group in the chat window. And if you want to ask questions about the presentation, please use the Q&A functionality of Zoom at the bottom of the screen. If you want to anonymize your questions, you can do that by checking the corresponding box in the Q&A message window. Questions will be answered at the end of the presentation. We assume we will have around 15 to 20 minutes for your questions. As you see, the webinar is being recorded, and the recording will be available for viewing approximately a week after this live webinar on the Pajunk GmbH YouTube channel. Our speakers tonight are Dr. Ansgar Harms and Dr. Jeroen Vogelaar from the Netherlands, who will be taking over now. Enjoy the presentation and thank you.
Thank you, Nick, for this kind introduction and of course for the possibility to share the enthusiasm of Ansgar and I concerning this topic. We are both working in a Vicurie Medical Center in Venlo, the southern part of the Netherlands. And we have no disclosures, and this will be the agenda we will talk you through. We thought it was nice to start with some historical developments on surgical and on anesthesiological parts, and then we walk through the whole talk. So first, something about history. The history of abdominal surgery demonstrates a magnificent evolution from the ancient years to the present. But as a surgeon, I think with a lot of anesthesiologists in the audience, I have to behave a little bit modest because the major landmarks in the development of abdominal surgery were not typical surgical. So the drastic progress during the past centuries was initiated by the development of anesthetic techniques. The other important landmark in history was the recognition of antisepsis and antimicrobial therapy as a key component of favorable operative outcomes. Nonetheless, surgery is invasive and subjecting the human body to significant stress with impact on a variety of systems, cardiovascular, respiratory, and immune. And of course, consequently, surgical stress affects organ homeostasis, which may be well tolerated by fit subjects, but also gives possible and significant risk to frail patients. And that is the group we are especially interested in. Irrespective of physical status, surgery causes pain, and pain itself causes stress. So after these landmarks, it soon became clear that small incisions induced less operative stress. Well, anesthesia and analgesia and antisepsis have provided a stable foundation for general surgery. For many years, investigators and surgeons have struggled to reduce the size of incision. It was more than 100 years ago that George Kelling performed the first laparoscopy on a dog. And his colleague, Christian Jacobus from, I think it was Stockholm, he performed a lot of research and also did the first laparoscopy in human. And again, there's a small role for the surgeon because George Kelling was an internist of all people, just like Jacobus, and was a gynecologist from Germany that performed the first laparoscopic appendectomy. But finally, there came the surgeon. It was Eric Muir, and he performed the first laparoscopic cholecystectomy. So this is about the development of laparoscopic surgery. So things changed in years. This picture is about 100 years ago, when the scrub nurses looked like aliens, and the bottle of gas was the only thing the anesthesiologist could use. And nowadays, this is the normal situation in most of the operation theaters, and maybe even in some theaters the robot has taken place. But still we have incisions, and still we need pain therapy. So that's, I would like to ask Ansgar to tell us more about it.
Well, I'll give a short summary about the pain therapy and what happened through the years. In the 80s and 90s, the 2000s, and now that we are talking about laparoscopic surgery. Can you do the next slide? In the 80s and 90s, it was days before the operation. The patient had to fast. The bowels were cleaned by purging. Anesthesia was just general anesthesia. In the 80s, you didn't use any epidurals because you just hadn't any suitable material. In the 90s, we first had to convince the surgeons that epidural analgesia and anesthesia doesn't do anything to their anastomosis. Pain management was done with morphine. We often had postoperative nausea and vomiting, ileus, no enteral feeding until the first passage of stool. So patients had to stay just on IV liquids the first couple of days after the operations. And yeah, hospital stay was very long. Next, please. In the early 2000s, we still had open laparotomy. Always there was epidural unless you had a really strong contraindication. We started with pre-habilitation. Eating was allowed as long as possible, and as soon as possible was restarted after the operation. We gave less fluids than earlier. We did prophylaxis to avoid nausea and vomiting. But there still were some problems because of the catheter for the urinary and the epidural catheter. Patients couldn't mobilize as fast as sometimes wished. But there was a extremely faster discharge after than with earlier protocols. Next, please. This is a picture of pre-habilitation. You see the red line where the patient is just stable on his pre-operation status, is being brought down to under his level, and after the operation has to recuperate very slowly. With pre-habilitation, we try to improve the status of the patient before the operation. That's the green line, with the operation, we took the patient only very short under the minimum level of functioning, and after the operation, the recuperation was very fast. We tried to get it faster. Prehabilitation, what does it mean? It means exercise before the operation, feeding as long and as good as possible, meaning that cancer patients get extra feeding to make them just a little bit better if possible. A big part of prehabilitation is education of the patient. We try to make them stop smoking. And in recent times, we also correct anemia just to make the start faster. Next picture, please. The next step was the laparoscopic surgery. That's what Jeroen already mentioned. With laparoscopic surgery, you have less pain. With less pain, it's slowly becoming interesting if you really need an epidural for the pain therapy. Certainly because the last 10 years, there were some studies pointing at rather high numbers of complications with epidural anesthesia. There were up to 1 per 1,000 to 1 per 6,000 serious complications with epidural anesthesia. And as well as with the what I earlier said, the mobilization is very difficult with epidural catheter and with urinary catheter. And yeah, discharge is just faster if the patient gets mobilized fast. But there still remains a problem. You have just a small incision still necessary to get the tumor out. And yeah, what has the anesthetist to offer in this case? There are some regional techniques. The transverse abdominal plane block, the transmuscular Quadratus Lumborum block, and the erector spinae block can be used for this, just to anesthetize the abdominal wall. Next one, please. This is a picture of the ultrasound-guided transversus abdominis plane block. Next picture, please. There you have the Quadratus Lumborum block. As you see on the picture, it looks a little bit complicated. In real life, it's not easier than on this anatomical picture. Next picture, please. There's the erector spinae block. It's easier to perform. You see the indications. It could be used for abdominal surgery, thoracic surgery, breast surgery, spine surgery, chronic pain, rib fractures. I've used it for some of these indications, and it works rather good. But we don't use it for the abdominal surgery. Next picture, please. Why we don't use it? If the incision crosses midline, you would need a double-sided block. The block is just performed as single shots. Then it works a couple of hours, and that's it. Then it works out. You could use a catheter, but for these blocks, that's always high volume blocks. So you would need rather high concentrations and rather high amounts of local anesthetic. I don't know how it's with you, your patients, but our patients don't have the optimal BMI for ultrasound of 20 to 25, as in workshops or in books. Another problem is that after the operation, it's actually too late. Before the operation, a awake patient, to prick blocks on awake patients, if you will make them asleep a couple of minutes later, isn't really friendly. So you would have to do it after the patient sleeps, and then the surgeon would have to wait. Our surgeons don't like to wait. The timing, anesthetists don't like to start much before the surgeons do, so getting up an hour earlier to do some kinds of blocks, my colleagues don't like that. Thus, what do we do with the laparoscopic surgery? We just give standard pain therapy with opioids and some paracetamol. You could use NSAIDs, but that's no option because our surgeons have some problems with presumably more anastomotic leakages when using NSAIDs. There is some discussion over this, and it will be followed. There are studies going on, and we'll see if that can change the next couple of time. What patients are we talking about? We're talking about older age. We're talking about multiple comorbidities. We're talking about frail patients. And all these patients are prone to opioid side effects. So that's a little bit difficult. Jeroen will tell something about the patients of the...
Yes, thank you, Ansgar. Colorectal cancer is one of the commonest cancers in the Western world. And this graphic shows us that the peak incidence is about the 77th decade. And this picture is the colon cancer incidence in the last 25 years in the Netherlands. And also here, the two, the purple and the light blue line are the age groups above 60 years old. And this one is the rectal cancer incidence. The graphic is about the same. And you see an interesting peak incidence about 2040. And this was the year when the population-based screening program for colorectal cancer started in the Netherlands. So that's the reason for the peak. This is a typical picture of the older population with colorectal cancer suffering from substantial comorbidity, especially cardiovascular, diabetes, COPD, and hypertension. And therefore, it's important to try to find out which patients are prone to side effects of treatment. So therefore, in our hospital, we screen our patients for frailty according to the international guidelines, and we have chosen for a two-step approach. The first step involves a geriatric screening test to identify patients who might be at risk of being frail, and we use the G8 score and the 4-meter gait speed test. And when one of the tests will be underscored, the patient is sent to a geriatrician for a complete comprehensive geriatric assessment. So the pre-screening does really work well. Otherwise, you have sent all the patients to the geriatrician, and it would take a lot of work. So frailty is an important item, also in colorectal cancer, due to the rapidly aging population. Preoperative frailty is not only independently associated with mortality, it might also be influenced the recurrence-free survival. So all the efforts are tended to minimize the perioperative risks. Ansgar.
Okay, yeah, without the epidural, the common alternative is the use of opioids. Everybody has heard about the opioid crisis in the US. In The Lancet, there was an article 2017 that 2 million Americans abuse prescription opioids. The sale of those quadrupled since 1999. According to the Center of Disease Control, 130 dead Americans are dying per day, and that's only the data of 2017. After that, there still was a little raise in this. Next one, please. You see on this picture how the development was. Looking at the curves, you see the almost exponential rise in the death toll starting around 2013, 2014. Next one, please. What about Europe? America is not where most of us people work, but in Europe, I've got some data from the Netherlands. The number of opioid users doubled between 2008 and 2017. That's reason, therefore, is that in that time, opioids were more and more used not only for cancer pain, but also for just chronic pain problems. The oxycodone use quadrupled. Obviously good marketing, not only in the US, but in Europe as well. The number of hospital admissions because of opioid problems tripled, and the addiction care doubled in that time. The mortality stayed rather at the same level between 2008 and 2014, and tripled between 2014 and 2017. It's still not the same amount as in the US, but it could become a problem. Advantages of less opioids is for every anesthetist daily business. You have less nausea, less vomiting, patients are less sedated. You see afterwards that there's less gastrointestinal ileus. Immunosuppression is becoming a hot item, and morphines or opioids are one of the possible reasons therefore. And yeah, respiratory depression is also less with that. Next one, please. Now there is an option of opioid-free surgery, opioid-free anesthesia. In a big review that I read with some 50,000 operation, 5 to 6% of the patients were operated opioid-free. The length of stay was shorter in the non-opioid group, but longer than what we usually need for our patients that we operate in Venlo with opioids. Laparoscopic surgery had less morphine milligram equivalents than open surgery. That's normal. It's just less painful, so you don't need as much morphine. And yeah, I'm not really convinced of that alternative. We've had some young colleagues who just came from university to strengthen our team in Venlo, and they didn't actually promote that opioid-free anesthesia. So maybe it's an option for the future, but I still am not convinced of that. So what are we actually looking for the anesthesia? We're looking, first of all, it has to be safe. Safe. That's the most important. We're looking for less or no opioids. It has to be easy and fast to do. It should be done by any anesthetist and any surgeon, so it should actually be foolproof. You would want as little preparation as possible to do this, and you would need little logistical efforts. If you have to order some special instruments weeks before the operation, that's certainly nothing you can use every day. And that's where Jeroen comes in.
Yes, and that's also where the continuous wound infiltration is probably coming on stage. So it potentially has the perfect combination of all the previous mentioned analgesic items and less side effects probably. But what do we know already from this technique? Because it isn't invented this year. There's already a meta-analysis from Sweden in 2011, which included 32 studies, and it showed that the most prominent superior effect of this technique was in obstetric patients. Well, those are younger, and those are women, of course. In all other groups, the continuous wound infiltration was non-inferior to any traditional technique. In general, there was a lower morphine use, especially in the first 24 hours, and also a little shorter hospital stay than the traditional pain therapy. And it showed a very low incidence of complications. But it has to be said, this study is very heterogeneous. and not only the type of surgery were very different, also the types of incision, and there were a large amount of open procedures. Nowadays, more than 75–80% of all the colorectal procedures will be performed in a laparoscopic mode. And there was also a difference in technique of positioning the wound catheter. Only 4 of these 32 studies in this meta-analysis concerned colorectal procedures, both open and laparoscopic. And this review, a little bit later, 2030, also very interesting because it compared epidural with continuous local anesthetic wound infiltration techniques. And the primary aim of this study was to compare these 2 methods with regard to post-operative pain, of course. And they used a numeric rating scale. And the secondary aims were to compare the morphine requirements, opioids requirements, nausea, vomiting, urinary retention, and the local catheter-related problems and treatment failure. This review included 9 studies, and again, significant heterogeneity, unfortunately, between all the included studies, and there were various types of abdominal surgery. Also, from a surgical view, there were several incision types: subcostal or lower abdominal, midline or transverse, and maybe very important, different positions of the catheter. Only 3 of the 9 studies had a ERAS-like or any enhanced recovery program. So this is not really mirroring the situation of nowadays, but gives us more information that it demonstrates that local anesthetic is non-inferior to we usually used for laparoscopic colorectal surgery, namely epidural. But the epidural analgesia was associated with non-significant trends towards reduced opioid use, lower pain on movement when it was administered continuously, but it was associated, as Ansgar told us already, and we know from the daily practice, with a higher incidence of urinary retention. And also in this analysis, low rates of complications of the catheters. So it might be interesting that the clue is in the position of the catheter, because the peritoneum might play a large role in postoperative pain. And that's this study. It's from the group of Mark Besselink and Munkroop in Amsterdam, 2019. And the aim of this study was to assess the outcomes between the pre-peritoneal and the subcutaneous placed wound catheters. Because the subcutaneous catheters only anesthetize the upper layer of the abdominal wall, but as said before, there's growing evidence that the peritoneum plays a large role in the postoperative pain. So they hypothesized that pre-peritoneal catheters are associated with comparable outcome to epidural analgesia, and they are superior to subcutaneous catheters. 26 studies are compared. As you can see, what they compared: continuous wound infiltration with the 2 positions, also versus the active control and versus saline. The endpoints were the pain scores at 12 and 48 hours postoperatively, the opioid consumption, the pain treatment related complications, technical failure, and all the other things mentioned here on the sheet. So the conclusion of this review was that it was the first systematic review and meta-analysis that showed continuous wound infiltration as effective for pain management in abdominal surgery, and the peritoneal placement was more effective than the subcutaneous placement. So that may be the clue for our practice. And on the left on the sheet is from my Sobotta Atlas. And the reason I put the picture here is that we, for most laparoscopic colorectal surgery, we use the small incision, the so-called Van steel incision, and that's in the area where the linea arcuata, it's below the linea arcuata, so there's no posterior fascia. That means that there's a perfect place and where you can put a catheter, because the peritoneum in that area is very floppy and not fixated to the fascia. That's the reason why it's easier to perform it in laparoscopic surgery compared to the picture on the other side, open surgery. It's not always easy to close the peritoneum, and there are also some drawbacks. For example, previous surgery that you even cannot close. There's a lack of peritoneum, or in large tumors that you have to remove peritoneum, or a loop colostomy in case of rectal cancer. This is the stepwise the technique of the continuous wound catheter. In our hospital, the pharmacist prefers the elastomer pump after we prescribe it at our OPD, outpatient department. It can also be prepared by the assistant of the anesthesiologist during the operation, but we choose to have it prepared by the pharmacist. Important to mention that before we start the operation, we always infiltrate all the trocar ports with a local anesthetic, and you can perfectly see it with your camera that you put a depot in the pre-peritoneal area. Well, after we perform the resection, we take out the specimen through the Van steel incision, then we close the peritoneum, and then we place the catheter. I will show you in a movie on the next slide. And then we give a bolus of 20 milliliter ropivacaine with this concentration. And then for 3 days, the elastomer pump is filled for 3 days with 5 milliliter per hour. Before we start the movie, I would like to mention some small pitfalls that can happen on the nursery ward. There can be a leakage. It can be simply helped with a gauze, or we call it tegaderm. The catheter can be luxated, unfortunately. Well, then you cannot replace it because it's placed during the operation, and it can give insufficient pain killing. So then you have to check first if the infuse is open. We had 2 patients 1 month ago that we didn't open that white the white thing on the tube. So after we opened it, it was much more comfortable. I will run through this video. Well, at this time the specimen is taken out. The peritoneum is closed, and then with a punction and a needle, after removing the needle, we put in the catheter. We chose, and here you see the holes in the catheter with all the drops. So you check if it's open, and this is the 7 centimeter we chose for this incision, where the ropivacaine is coming out. Then you remove this, and the catheter is placed on the peritoneum under the fascia. You see a small loop, but in here we straighten the loop so there will not be a knot after removing. And then we use this fixation material. And after closing the fascia, the bolus will be given. And totally this will take, well, I think 3 to 5 minutes. And this is the bolus of ropivacaine. And with a little key, you can put it on the concentration you like to give. And maybe Ansgar can tell something about the safety of the concentration we use.
Yes, I can. There was a study with transversus abdominal plane blocks where they put two-sided catheters in the wound. Did rather high doses for the loading dose with 400 milligrams with patients both above 70 kilos. And after that, an infusion of 28 milligrams per hour for the first 24 hours, which would be around about 672 milligrams per 24 hours, and up to 2,260 milligrams in 72 hours. With our regimen, we only use 40 milligram bolus, and after that, 700 milligram within the next 3 days. So we stay much below the tested regimen of the people around Hessian. And yeah, that's what I consider a safe method.
Yeah, and I think there might be space to maybe personalize or to enhance the 40 milligram, but that will be for future study. After a small and successful pilot, we implemented this technique in our hospital, and we shared the results with some colleagues, and especially my colleague Dr. Blumen, surgeon in Catharina Hospital in Eindhoven, was also very enthusiastic, and we both are now conducting a prospective analysis of patients of our hospital. And I will show you the preliminary results of our first 138 patients. These are the results of the both hospitals. And there was a little spoiling of non-colorectal cancer operations, a small bowel resection, a cholecystectomy, and maybe also some ileocecal sections for a Crohn maybe, but the general were all laparoscopic colorectal cancer operation performed in our 2 hospitals. The median length of stay before we implemented was between 5 and 6 days. To be honest, more near 6 than near 5 days, the median hospital stay. And after implementation in this series, the median length of hospital stay is 4 days in our hospital, and it's even 3 days in the Catharina Hospital. What has to be mentioned is that the Catharina Hospital has now implemented the latest ERAS protocol, and we are now starting up for the refresher course. So we hope to also win some days, but this is a win of at least 2 days compared to 2 years ago. The opioid use on the first day of the day of the operation was a little bit different, but still, well, quite a lot of patients need some morphine, so maybe there will be some winning of higher bolus, or we will discuss it maybe later. But 65% of the patients, so 2/3 of the patients, don't use any morphine or opioid-like medication on the day after the operation. And the second day it's even lower. Only 25% is using opioids. So, well, we were very happy with these results, and also the maximum pain scores, with a scale from 0 to 10. is low and also comparable, I think, with the epidural scores from the literature. So what will we discuss in the future? In our hospital, we would like to implement it in the acute and the laparotomy setting. You need a slightly different technique because of the closing of the peritoneum and the larger incision. It's a kind of a tunneling, maybe with 2 catheters, but we will find out. We didn't do it yet. According to literature, the highest level of evidence is also there for the cesarean section. So I'll try to make our gynecologist also enthusiastic for this technique. And from our orthopedic surgeons, I know that there's a randomized controlled trial together with the Maastricht University in spondylolisthesis patients, also with the continuous wound infiltration. And in general, as I mentioned before, the fine-tuning of the dose, maybe we can work to a patient-specific dose, and we have to implement it in ERAS protocols together with the whole team. From a scientific viewpoint, it would be very interesting to measure the effect on inflammation or immune system, or even maybe cancer cell development, etc., especially in this population. So coming to our conclusions, the continuous wound infiltration catheter in laparoscopic colorectal surgery is, in our opinion, feasible, very safe, and easy to perform. It reduces morphine use, it minimizes pain scores and helps to shorten the length of stay, and it perfectly fits in any ERAS-like protocol, and it's particularly interesting in the older population. So that was what we would like to share with you, with special thanks to the research students of our study, and my colleague Dr. Bloemen from the Catharina Hospital, and our pharmacist in Venlo, and of course Ellie Roos for all the practical support, and my son Jelle Vogelaar for editing the wonderful movie. Maybe there are some questions. I think there's a question for Ansgar. It's from, do you ever use spinal opioids or lidocaine or IV ketamine, and what's your opinion about that?
We don't have any experience with spinal opioids. I read about it, but we don't use them ourselves in Venlo. Some of my colleagues use IV lidocaine, and sometimes we use IV ketamine, depending on the kind of patient we get. Yeah, we're still experimenting with it. We don't have an actual protocol for this. Okay. The next question is, what about continuous spinal anesthesia? I think there you would have the same problem with an epidural catheter, also with a spinal, continuous spinal anesthesia. You would have problems mobilizing the patient, and actually you would use that for longer pain therapy. And our main aim is to get the patients mobilized as soon as possible, and get them moving and out of the hospital as soon as it's possible.
Okay. Another question was about review. What kind of gynecological procedures? Those were mainly the cesarean sections, and that was the group where the effect of the continuous wound infiltration was the best. So they had the longest effect, longer than 24 hours of the analgesia. And one question, next question is, there was, let me see, there was a lower wound infection, lower wound breakdown in the group of the wound catheter in the review. Ansgar, can you explain why that could be?
No.
Can it be the effect of the local anesthesia? Is it antibacterial?
Local anesthetics are antibacterial. In any case, yeah, bacteria don't grow in local anesthetics, so that could explain part of it. That's also a reason why you don't see infections or a lot of infections when local anesthetics are used. So that could explain that. There was a question about different local anesthetics, ropivacaine, bupivacaine. I think you could use anything in a rather low concentration. We use ropivacaine 2 milligram per milliliter. That would be equivalent to bupivacaine 0.125 milligram percent, sorry. And that would also do the trick. Only we chose ropivacaine because it's considered a little bit safer on cardiorespiratory problems.
Okay. Another question is, in our units, most surgeons do not close the peritoneum. Obviously, this technique won't be efficient without peritoneum stitches, question mark. It is necessary to close the peritoneum. As mentioned, it's most easy in the phalansteal region, but with, for example, a midline incision, it isn't always that easy. And before we don't use it yet in that situation. So also we don't close it specifically. I know in the Catherine Hospital where they perform more redo surgery or locally advanced surgery after previous surgery, they intend to close, to the best of my knowledge, all peritoneum incisions. But it's true that you need to close the peritoneum to have the maximum effect of the ropivacaine.
Here's a question about the systemic effects of the continuous wound infiltration. Well, if I look at the patients in the recovery wards, I see that they don't have any pain with the incision where the catheter lies. And for the rest, they do have rather normal pain from the laparoscopic wounds. They do need some morphine, but it's just in total less than they used to need before we used this technique. So I would say it's more the local effect than the systemic effect.
Okay. Then a technical question of the precise position of the and the direction of the catheter in the phalansteal incision, because the incision in the skin and the fascia is in a transverse direction, and then you open the muscles in a median way. Well, the catheter is from laterally, as you could see in the movie, placed under the transverse, under the muscle. So through the fascia, through the muscle and on the peritoneum. And there was a question, are there any issues with the infection? In our series, there were no complications of infection in the wound catheter. We had 2 patients, I think 1 in each hospital. I think that the catheter was fallen out because of traction or something. So that was those were 2 failures.
A question about the intraoperative use of lidocaine infusion and regarding the LA local anesthetic toxicity afterwards, if we still use a catheter. We did that with some patients. We didn't see any problems. You would just have to look at the patient and act from case to case. I don't have any data of toxicity of the combination of lidocaine and afterwards ropivacaine.
Okay. Do you need to pass the NOAC, the blood thin medication, before inserting the catheter? Well, usually, unless there's a very firm indication for the NOAC, we stop the NOAC 2 days before surgery. So the effect, that's also the effect on the inserting catheter. A question about rectus sheath catheters. I don't have any experience with the rectus sheath catheter. Maybe, do you have, Ansgar?
No, I don't.
No, I'm sorry, no.
A question about what opiate we use. We use normally morphine, but pyritamide would do the same. And I think it doesn't make any difference which opiate you use. During the operation, we also always use remifentanil to get the patient fit faster after the operation.
Mm-hmm. And a question about a remark and a question. Pain is a very subjective outcome measure. Are there any randomized data? Well, the randomized data available, I try to share in the meta-analysis in this presentation, and of course it is very subjective, and the studies I showed, there can be a statistic significance of pain scores between, for example, epidural and continuous wound infiltration, but the statistical significance of a pain score of 4 compared to 2. The question is that clinically also significant? So that's a good point. Second remark from my side, that we hope maybe it's possible to personalize it before you start operation. What kind of patient, what kind of procedure needs a higher concentration, or more than 5 milliliter per hour, for example.
I see a question here about pausing of NOACs before inserting the catheter. For the catheter itself, that's no problem, but I think no surgeon would operate abdominal surgery with NOACs actively. No. So that's no problem in that betref.
Okay.
Oh. What?
Let me see. Spinal anesthesia with hypobaric anesthetic produces no motor block. Would that not be an option? That's a question for you, Ansgar, I think.
We don't use any spinal anesthesia for abdominal surgery because, it's you have a lot of problems with hemodynamics, and that's why we don't use it. Morphine could be an option, but we don't use any spinal anesthesia in this.
Are there any contraindications? Well, actually, the only contraindication is when patient cannot do have an allergy against ropivacaine. So, to the best of my knowledge, that's the only contraindication. Yes.
I see a question about the erectospinal block. If it's a good popular technique of analgesia in this in abdominal surgery. Well, the erectospinal block works for the abdominal wall, so it would be rather suitable technique, but also here you would need catheters and you would need high volume, and it's more difficult to apply than just let the surgeon put in a catheter and connect the elastomer pump.
Another question, does the level of experience of a surgeon and anesthetist affect the results of the studies? And should this normally be examined in a study? Well, the movie I showed, the catheter was placed by one of our residents. And just like Ansgar showed in one of his slides, it's quite foolproof. So even a surgeon can place it in a quite easy way. Yeah. So I think there's no experience. There's no experience issue.
Another question about the local anesthetics we are using. We don't use any marcaine, but that's just a choice of our hospital to use the presumably safest local anesthetic, and that's the ropivacaine in our case.
Any experience with children? We don't have, and I don't know if there is, but I don't know. Is there any pain difference between colon and rectal surgery? And so do we need to purpose epidural analgesia for laparoscopic or robotic rectal surgery? Rectal surgery in case of an rectal amputation, then the most painful wound is in the peritoneal area. I think it's easy to place a catheter in that area, but it has only a local function and there's no peritoneal space to place it there. So also the patients in our hospitals, there were also patients with rectal surgery, and they also had good effect of the wound catheter. But indeed, rectal surgery may be more extensive than colon surgery.
A question if it's effective to add adjuvants like dexmedetomidine or dexamethasone. We don't use that in our experience until now, and I think it's looking at that just a local working of the local anesthetic. I don't expect much profit from using any adjuvants.
How does the patient mobilize with the elastomer pump? Well, they carry a very small bag, sort of a cocoon-like, a cotton-like bag that can be easily carried. So that's not a restriction to sit on the bike the next day or to walk with the physiotherapist or etc. So the elastomer pump is not that heavy or something. No. Did you try different rates of ropivacaine? In some studies, lower rates were not effective. Well, a lot of studies, previous studies, were very heterogeneous, also in the concentration, but also in the kind of incision and the kind of position of the catheter. So that's why it's very hard to compare. We didn't try in a few patients that were painful, but I think that those were less than 3 or 4. We changed the concentration from 5 to 8 milligram with some effect, and also some without effect. But well, that's for future research, I think, to optimize and to personalize the concentration. How long do you leave the catheter in place? Well, with the 5 milliliter per hour, the elastomer pump is empty in 3 days, So we take it out in 3 days, or when the patient leaves the hospital earlier than 3 days. And another technical question, is it possible to use 2 catheters in a large incision? Yes, that is possible. And then you can use a kind of a tunneling technique to place it in the right plane, subfacial, pre-peritoneal.
Another question about the anticoagulation, rivaroxaban. Well, if that's used for the removal of the catheter, that doesn't make any difference. It's just taking out a catheter that's wouldn't do much harm, but we wouldn't start any anticoagulation until the catheter is taken out.
Can you use the usual epidural catheter set in this infusion? Ansgar, do you know?
Sorry, I was reading.
Can you use the usual epidural catheter set in this infusion?
You could, but the special catheter has many holes, so the local anesthetic is spread in a special in the whole area of the wound. You would use different length of catheters as well if the incision is longer, and the epidural catheter only has 1 or 2 or maximum 5 openings in the end. So that wouldn't be feasible for this technique.
Okay.
So,
any more questions?
I think one more question. Do you see a lot of leakage with the longer catheters? Actually, if the catheter is placed at the right space, you see some leakage along the catheter, but it's tunneled, and there is some space where there's no openings of the catheter, so there you don't see much leakage.
Okay.
Perfect. Thank you all for your attendance and all the questions. Big thank you to our speakers for the presentation and all the answers they provided. We hope you enjoyed the session. Invite you to the upcoming industry education webinars, which will be announced through the ESRA website and the ESRA newsletters. We wish you a good evening, and thank you for all the work that you've been doing with COVID-19, and stay safe. Thank you.